Ladies and gentlemen, please welcome Executive Director Barbara Kelly.
Good morning, everyone, and welcome to the 31st HLAA Research Symposium. You know, hearing loss can be the loss of many things, but perhaps most importantly, it's the loss of connection to other people. Today's symposium addresses the powerful emotions that follow from hearing loss and how they impact our behaviors, how we harness them for a more successful hearing journey. Before we hear from our speakers, I want to acknowledge the sponsor for our research symposium, the National Institute on Deafness and Other Communication Disorders. It's located within the National Institutes of Health, and the NIDCD is our nation's premier center for hearing research and a major funder of science in this field. It's a tribute to HLA's fine reputation that the NIDCD chose our organization to receive funds to get the message out about hearing loss and the science behind it. And we're very grateful for that support, which enables us to provide today's program. We have a distinguished panel of speakers today, and you will find all of their bios in the program. The first speaker will be Dr. Barbara Weinstein, and she will speak on the loneliness epidemic and the importance of hearing healthcare interventions. So thank you for coming. Dr. Weinstein?
Thank you, and thank you for inviting me to this important meeting. The emotional side of hearing loss has been... I have to turn my phone off. That's interesting. The emotional side of hearing loss has been something that has been of interest to me since I got my Ph.D. in 1980, and my interest has only increased rather than decreased. So, as we all know, hearing loss is a social sense, it's a safety sense, and it's critical to overall well-being. Hearing loss is a problem because it affects quality of life, it's a risk factor for medical and psychological conditions, there's a lot of individual variability, however, in the reaction to a given hearing loss. So, for example, we have Thomas Edison, who felt that having a hearing loss was an advantage. It meant that he didn't have to concentrate when people were talking, and he kind of removed himself from connecting with others so that he could do his science. In contrast, Helen Keller felt that deafness was a misfortune, and that not being able to hear people's voices ended up making her lose contact with others. She felt that the problems of deafness were deeper and more complex than visual loss. So why is it that some people end up withdrawing when they have a hearing loss? It's kind of interesting psychologically. So what happens is you interact with, as many of you are well aware, you interact with friends, you're having difficulty communicating, and you're motivated to communicate. However, when you're in challenging listening situations, the demands are considerable. It requires a lot of listening effort to focus. Fatigue can set in. You lose your motivation to participate because the rewards of participating may not be worth the effort you have to put in, and consequently, individuals tend to withdraw. But social connections, as everybody here knows, really matter. Meaningful relationships stimulate the growth of new neural connections and support neuroplasticity in the brain. Neuroplasticity continues into people's 90s. The brain is wired for social interaction, facilitated by neurotransmitters like oxytocin, which promotes emotional resilience and reduces stress. So engaging in positive social interactions is associated with reducing lower stress levels and contributes to reduced risk of chronic conditions. So there's physiological reasons why social interactions are important. But I wanted to start by kind of distinguishing between social isolation and loneliness. And we know that loneliness is kind of a big deal now because the Surgeon General said that we're experiencing a loneliness epidemic, but I do want to distinguish between the two. Social isolation, on the one hand, is an objective and quantifiable reduction of reduced social network size and a paucity of social contacts. It's really an objective indicator of social connectedness. It's about the number of social contacts, and it's a situational phenomenon. In contrast, loneliness which I said is an epidemic, according to Murthy. It's biological and it's an experiential phenomenon. It's a subjective feeling about your social connections. And loneliness, you could be around people, you could be in a crowded room, but you could feel lonely because you're not, the connections are not meeting your expectations. And oftentimes people have anxiety about being in a social situation where they're not feeling a part of the situation. So according to the Surgeon General of the United States, loneliness is like hunger. It's a signal we're lacking something for survival, which I thought was very, very moving. So when one is lonely, it's a signal that there's something wrong in their environment. And lonely individuals perceive their social environment in general and social situations in particular as being threatening. And many of you may feel this, experience this. However, social isolation and loneliness, important to say, different sides of a coin, different social constructs. Social isolation, again, the actual tangible absence of social interactions. It's when you don't have people around you with whom to have contact. Loneliness, on the other hand, it's about feelings and perceptions. One could be surrounded by people, but can feel disconnected or unfulfilled by the relationships. It's not just about how many people you interact with, but it's the quality of the interaction. So we're really focusing on quality here. So what are the impacts of socially disconnecting? The impacts are widespread. So there's impacts on the individual, there's impacts on relationships, and there's impacts when you're in large rooms within the community. And there are costs of these socially disconnecting. In terms of the impacts, there's an increased risk of premature mortality, as much as smoking up to 15 cigarettes a day. So socially disconnecting cuts your longevity down more so than smoking a lot of cigarettes. You have an increased likelihood of depression, anxiety, cognitive decline. Loneliness and socially disconnecting have economic impacts. Medicare spending is increased, and there are physiological changes to the brain. A lonely brain can be transformed to be worse. Neurotransmitters are important for bonding and social connections can go haywire. There is atrophy in the part of the brain, the thalamus, which processes emotions, and in the memory center, the hippocampus. And the changes in the brain can help explain why lonely individuals perceive their social environments as threatening. I don't want to scare you because you folks here are all obviously connecting. So hearing difficulty is a modifiable risk factor, and hearing really, really makes a difference because the brain can snap back from loneliness. So what are some of the triggers to social isolation and loneliness? There are predisposing physical health factors, there are psychological factors, there are social support factors, life events as we age, there are gender issues, environmental factors, transportation, housing, and sensory impairment is now considered an important trigger. And here we have a little bit of a schematic showing, this is from the Public Health Agency, that shows sensory impairment being a risk factor for social isolation and loneliness. And this is one of my patients in her voice. Isolation and loneliness are common when you cannot comfortably hear and communicate. You retreat as you feel safe in silence. You get gun-shy going out into the real world, worried your dark secret will come out as if you committed a crime. The loneliness I feel because of the garbled messages I received, hearing loss is my personal Mount Everest. And she didn't think that there was anything that could help her, and we certainly did make a difference. So let's look at the connections between hearing loss, loneliness, and social isolation. What are the data? So let me just share the stress hypothesis, which physiologically can explain some of the impacts. So it's important to be able to self-manage in different environments, and each of you here has HLAA is the most amazing organization for many reasons, but you learn from each other how to deal with the challenging listening situations and how to adjust to and self-manage in these difficult environments. But some people cannot. And when you cannot manage the social environments, social relationships become deficient. You can feel isolated, you can feel lonely, and the stress hormone is released. And when that stress hormone is released, This increases the risk of depression, increases the risk of cognitive issues, and so that the stress hormone is released when we're in stressful environments. So there are physiological changes. And the effect of a person's hearing function can be one of those stress factors unless you're able to self-manage it. So a challenging acoustic environment in which people are trying to hear, listen, and communicate can jeopardize the quality of interactions and can induce feelings of loneliness, as many of you may experience. Older adults with hearing loss themselves do feel lonelier than older adults who do not have a hearing loss, and I'll share some of the data on that. So let's look at some of the data. Many of you have heard of the ACHIEVE study, but most of you have heard of the ACHIEVE study in its connections to dementia. And I'm not going to discuss that one because that's been out. What I wanted to talk about is this multi-center randomized trial of a large group of older adults. I wanted to talk about its findings in terms of social connections. So there are participants in two different groups, and there was one group of participants who received hearing interventions, and the other received some form of health education as a control group. And both groups were followed for 3 years. And this study just came out 2023. What's interesting is some of the findings on loneliness. So they measured outcomes, loneliness, they measured self-reported quality of life issues relating to hearing loss, and they did a lot of hearing measures. So they measured speech and noise, understanding, they measured pure tone hearing, and they measured self-reported hearing loss. So we know there are different, the audiogram doesn't tell all, so you have to have a lot of different measures to understand how hearing loss affects people. So what they did find was that the prevalence of loneliness was higher in the sample with hearing loss than in the general population. And what they found is that speech understanding and noise, which many of you experience, was associated with a lower number of contacts and lower number in terms of the diversity of social contacts. Hearing status, that is the audiogram, what they found is that the prevalence of loneliness was higher for people with moderate hearing loss, but not associated with the social network size. So hearing status was associated with loneliness, but not as higher an association as the self-reported difficulties that people experienced. Self-rated hearing difficulties, what people told the audiologist, was related to a greater prevalence of loneliness, poor loneliness scores, a more constricted social network, and fewer domains of social involvement. So it's important that the audiologist hear from you exactly what you're experiencing in addition to what they're measuring. And the conclusion in this study was that hearing-related quality of life that is the self-rating of hearing loss, may be a potentially useful, easily administered tool for understanding auditory wellness. And just my study, which I did in the 1980s for my dissertation, I'm the first person to look at social isolation and hearing difficulties, and most people didn't care about it because in those days, in the 1980s, 1970s, it was normal for older adults to socially disengage. It was part of the disengagement theory. And what I too found was that self-reported hearing difficulties correlated most strongly with network size and loneliness. When we did find that people with the most significant hearing difficulties were the loneliest and the most isolated. But there's good news, because I don't want to just be a progenitor of bad news. Audiologists to the rescue. Yeah, so the data. So let's look a little bit about the efficacy of selected hearing interventions for people who are experiencing hearing loss. So I did a study in a private practice in New York, and we looked at the impact of hearing aid use on feelings of loneliness and on hearing-related quality of life. And with this study with people who went into a private practice, the average age of the first-time hearing aid users was 82, which is unbelievable. And what we did, and we gave everybody, we measured a lot of different outcomes, and we did find was that use of hearing aids did reduce the feelings of loneliness in this population. And what we also found was that pre-hearing aid fitting, that's on the left, what we did find, that's the green, what we did find was that more post-hearing aid fitting, more people were not lonely than before the hearing aid fitting. And then on the loneliness side, what we did find was that pre-hearing aid fitting, more people were lonely than after the hearing aid fitting. So we did find that the hearing aids did impact feelings of loneliness. And that was one of the first studies on the impacts of hearing aid use on loneliness and social connections, and now there are many more studies. This is not a randomized controlled trial, but it was one of the first studies in the area. And most recently, and I think many of you will appreciate this study on cochlear implants just came out, a large-scale study. And here too, and I'll explain it, but I thought the slides were nice and colorful. So what you could see here on the left, what you see here is after 18 months of cochlear implant use, you see a dramatic reduction, improvement in hearing-related quality of life in terms of people were more connected, they were more socially involved, and they felt less disconnected. And then in terms of loneliness scores, also what we do see is that after 18 months, the loneliness scores were much less. So people were much less lonely after using cochlear implants, which was a pretty, I think these are very important findings given how important cochlear implants are. And we need more people, of course, to use them. In terms of that study, by 18 months, at least 50% of participants were able to use the telephone and 25% were able to score at normal hearing levels. So the implantation really improved the ability to use the telephone with their implants. And this improvement in hearing was reflected clinically and statistically significant reduction in handicap, which I mentioned. What was interesting is that better hearing included the restoration of the ability to use the telephone, and that also might have had an impact on loneliness. And I'm just going to put a plug in here. So if some of you are still having some difficulty on the telephone, there's going to be an InnoCaption. There's an InnoCaption group here, and this is call captioning, so that you can use a mobile telephone and you can use call captions, which really does make a difference. It's proven, we found that it does reduce the experience of loneliness. So for those with difficulty on the telephone, you may want to talk to those people. So in conclusion, what they found was that cochlear implants contributed to overall well-being, and cochlear implants, as an audiologist, and as all of you know, should be a treatment option for those people who are 60 and over who are still having difficulty with their hearing loss. So I try to push for it and try to get audiologists, and we know that Cochlear is here, and they're doing as much as they can in Medell to get increased use of cochlear implants. So what's the audiologist's role? The reason why I'm mentioning this is because I did a survey of members of HLAA in New York. Some of the people are here who were at that session where I presented my results. And what I did ask the participants, this was before the pandemic, and I said, if you had difficulty with your hearing and you were having difficulty socially, who would you speak with? And they said, I would go to social work, I wouldn't go to an audiologist, because audiologists are just trained to sell hearing aids and to recommend cochlear implants. They're not trained to help people with their hearing, and hopefully that's going to change. So this is my prescription for audiologists. We have to seek the participation of family members with hearing difficulties, and we have to socially prescribe, make sure people are remaining connected, and we have to understand how they are connected. We have to help people with hearing difficulty explore and compare different treatment options. We have to be guided by your patient, your values, your preferences, your journey, and your strategy. And we have to be collaborative with you, patient-centered. And of course, audiologists have to evaluate the outcomes of their interventions. So there's a 5-step program that a group of us came up with in a paper that we recently published. And the 5-step program starts with making sure to assess the person's emotional well-being. And then we have a 5-step program to kind of make sure we're engaged with the patients throughout their journey, and that we continue to see you and recommend activities and monitor activities in which individuals are engaged. So the word here is kind of social prescribing. So audiologists recommend hearing aids, audiologists recommend cochlear implants, and we should also recommend, and we should also follow through on making sure that your people are engaged in different activities, and we want to monitor those activities. We want to make sure that people are enjoying life, and we want to make sure that our patients are socially connecting, and that's what social prescribing is ideally for. It's something that's done in geriatrics, not so much in audiology, but some of us in audiology, including Dr. Pichora-Fuller, are kind of invested in the social prescribing area. And also I came up with a sample social prescription for audiologists to recommend. So in addition to recommending hearing aid use, it's important to recommend engagement. And I put in connections with food banks because a study in Australia revealed that people who are deprived in terms of food are more hearing handicapped than those who are not hearing impaired, hearing handicapped, which was kind of interesting. So some takeaways. We all know that the hearing loss has many invisible burdens. Isolation and from others, constantly being visually aware, which can be exhausting, missing out on conversations, having to always make sure that a space is accessible, and people not being aware that you have hearing loss. Audiologists are responsible and should be deconstructing your feelings, and I try to kind of encourage my students and the people I work with to work with people with hearing loss to help them deconstruct their feelings. Positive messaging is kind of like what my new thing is. Hearing loss is worth addressing in its own right, and this we're talking about this because of all the social media saying that you get hearing aids, you're not going to get dementia. Hearing aids are going to hearing aids are going to prevent dementia. That's not the case. Hearing loss is worth addressing in its own right. The major benefit of hearing aids, they reduce hearing, or cochlear implants, reduce hearing disability, optimize communication function, and facilitate social engagement. Our role is to help build and strengthen personal resources so that persons with whom we work can achieve optimal functioning and full inclusion. So our hearing interventions, and you should make sure your audiologist is on board with this, we must focus on patient priorities, wellness, and reserve capacities. We must incorporate strategies into our interventions designed to optimize communication, help to increase autonomy, environmental mastery, purpose in life, and healthy lifestyles. And we want to make sure that we are person-centered. It's about your values and your preferences and your priorities. And most important social prescription that I try to offer and that you all, I'm sure, know about is to remain connected. So one of my students created this. Social prescriptions for social connections are important for reducing loneliness, mental sharpness, safety, reducing stress levels, important for cognitive well-being, and important for activity levels. So socially prescribing for hearing health can improve brain health and auditory wellness. And thank you very much.
Okay, thank you so much, Barbara, for that fantastic kickoff of this session. Our next speaker will be Dr. Kathy Pichora-Fuller, and she'll be talking about where the science of hearing emotion meets emotional aging. Kathy?
All right. Well, Barbara, you are always so amazing. And I hope the audience really is happy that researchers are interested in this, and we need you to help us. So there's research I've done that backs up many of the things Barbara said. In the Canadian longitudinal study on aging, when we compared people with no sensory problem, vision loss, hearing loss, or both, it was exactly what Barbara said. What really stuck out was the loneliness being different and social support being different if you had a hearing loss. And social network and participation in activities wasn't the telling variable. So we are here because it's the research session. I'm also an audiologist, I'm also a gerontologist, and I'm going to take you into a little bit of a different dive into the science. And I'm thinking about some of the things I have learned that were new for me from Barbara, and I can't wait to get into the discussion with you. So, why do we communicate? You know, Barbara talked about the importance of communication. If you go to have your hearing tested, they want to know how many words you can repeat correctly. And I guess you do want to know what time your doctor's appointment is, so you have to get information right. But the truth is, the more important purpose of communication is interaction, social interaction, because communication is the thing that gives us the ability to establish and maintain relationships. So I'm going to underline that word relationships, which you already heard from Barbara. We also communicate, with music if we're doing art or worshiping. So there's a few other purposes of communication, but number one is establishing and maintaining relationships and interactions. And Barbara referred to this study and other studies like it, showing that social relationships are highly related even to your risk of dying. And it's right there on the map, as she said, with smoking. Smoking kills, so does a lack of social relationships. It's in there with drinking too much alcohol and being overweight. So this is serious stuff, and there's good science behind it. So let's just think about, why is hearing loss a problem? It's a problem if you can't hear things. But if you wear your hearing aid or your cochlear implant, you're hearing things. Is that good enough? There's a lot of good benefits that Barbara described because of rehab, and devices are part of it, but mostly devices make things louder. And what I'm going to tell you today is that that isn't going to necessarily be as helpful as we would like it to be in terms of you getting emotional cues. So communication is about the words, but it's also about how people say the words, the prosody or the music of speech. And communication is multimodal. So I'm sure many of you know a lot about speech reading, and you know about how speech reading can help you to get the words right. But watching people also helps you to figure out what emotion they are experiencing, which is so important. So emotional communication is more than language, okay? The audiologists never test this, but you experience it in your everyday life. So if you don't hear, you can rely on vision. That's a backup system. So if you want to understand the emotion of somebody you're talking to, do you hear emotion in their voice? Do you see emotion on their face? And there is a science about how people get cues from the face so that they can identify different emotions. So this is, textbook material about facial emotion recognition. So if you have fear, your eyebrows are going to be raised, your eyelids are going to be raised, there's going to be these changes, okay? So they're expressed in slightly different ways by slightly different people, but, we're pretty good at recognizing those emotions. There's kind of a counterpart in speech. So if you're listening to somebody's voice, how do you know if they're experiencing fear or sadness? Well, fear has a higher pitched, ah. Sadness has a lower pitch, ah. Speed. Fear is relatively fast speech. Sad is relatively slow speech. Intensity. Fear is going to be loud, and sad is going to be soft, right? So those are things that, an audiologist is not going to measure, but they're going to affect how well you recognize emotion in the voice. And I've heard people with hearing loss say, my teenager just grunts. They don't actually use words. They don't actually speak in sentences. But when they get up in the morning and we're having breakfast, I just want to know if they're depressed or happy. Okay, so sometimes these vocal cues are even more important than words. And sometimes you get kind of a mismatch. So the words may give you a certain message. I'm so happy. I'm so happy. Depending on how it's said, there may be a match or a mismatch. And you might get really confused if you're getting one thing from the face and a different thing from the voice and a different thing from the words. So this makes it really hard to navigate when all of the information you're getting from the words, from the voice, from the face, don't necessarily line up. My daughter-in-law, one of the things she likes to say is, wow, and that's a critical wow. It's like, I have never heard that until her generation, but, she invented a new expression. So I need to hear that emotion to understand she means, you've got to be kidding me. So what changes in age? I'm kind of looking out there over the audience, and I think most of you are probably interested in aging. So you've heard this expression, you kind of mellow in your old age. Yeah, have you heard that? So what does that mean? You know, technically we might say you have better emotion regulation or better emotional control. You know, so yesterday my husband woke me up and said, there's no ferries today, you can't go to the airport. And it's just like, oh, well, let's figure out how to solve that one. You know, do I have to swim because the ferry isn't running? Like, what am I going to do? But I did not freak out. So that's the benefit of being older. You've got this better emotional control. And as Barbara said, you know, there are things that are changing in your brain. Your emotions change, your hormones change, things are changing with cognition and how well you can reason through different emotional experiences, and perception, your hearing and your vision also change. So the good news is that, you know, you can control emotion better. The bad news is all older people, whether or not they have hearing or vision loss, they aren't so good at identifying emotion because there's all these changes in the emotion system and the cognitive system and the sensory systems. And one way older people tend to cope with that is by ignoring negative stuff and focusing on positive things. So I don't know about you, but I know a lot of older people, it's like, yeah, I don't want to talk to Joe anymore because he's so negative. So he gets kind of shunned. So being positive is a good thing because people like to interact with you socially. Okay, so in the lab, now I got my white coat on, and we are looking at younger and older people who have pretty good audiograms. These are not people who need to wear a hearing aid. And we measure how well can they identify emotion just in the voice. So what do you see there? You see across the board, younger people do better. You see that different emotions are more easy to recognize. So anger is a really easy one to recognize. Pleasant surprised, not so easy. So it kind of matters which emotion you have to recognize. And it's a little bit flatter for older adults than for younger adults. If we look at people with hearing loss, okay, I'm going to go backwards. You see that red line at 60%? Now we look at people with hearing loss, and we look at them with and without their hearing aids, and all of the results are below that 60%. So if you have a hearing loss, you cannot, if you're older, you can't identify emotions as well. If you have a hearing loss, you can't identify emotions as well. And wearing a hearing aid really doesn't help that much. Because hearing aids make things louder, hearing aids don't give you, you know, they don't compensate for your loss of ability to detect pitch differences. So people are working on this. So the manufacturers of equipment are hot on the trail of how do they get you the cues that you're missing, but we're not there yet. Now, does hearing the emotion of somebody's voice change how you recognize words? Well, yes, it does. That's kind of interesting. When you go to the audiologist and they give you a test with words, they're kind of boring, right? It's like, say the word dog. There was a very serious accident. You know, it's always very neutral. They don't actually give you real voices saying real things. The plane went into a dive. You know, that's the kind of stuff audiologists test you with. But if you test with emotion, so these are the same words that you get in an audiology clinic, but they're said by actresses portraying them with different emotions. And then we see how many they get right. And the emotion matters. Now, again, the young people are doing a little differently than the old people. The difference in the colors here is not the difference between young and old. It's between whether you're doing the test where every item, you know, it's an unpredictable emotion, or you get a run of tests where the whole run of them is happy, or the whole run of them is sad. So what we actually see is that when they are blocked, and you know, okay, it's going to be happy, you do better than if you don't know what the emotion's going to be. So that kind of makes sense. You know, if you kind of get that your friend is happy or sad, you can kind of tune into what they're saying a little bit better. And fear is the one that really helps you to understand words better. Because, you know, maybe it's a good thing to know if somebody's scared because maybe you have to get out of there quickly. Maybe it's a survival thing. So there are ideas about why some of these emotions vary. All right. And the good news is if we do look at age and we look over time, you know, throughout the list, from the beginning of the list to the end of the list, older people, by the time they've practiced, they can be as good as the young people were at the beginning. So practice can help. So these are actually things you can practice if you want to. This is a kind of a complicated graph. So if you don't like graphs, I'll just tell you what's going on here. So we have young and old, and we have sometimes they're listening to speech when it's just like background vacuum cleaner noise, just steady speech noise. Sometimes they're trying to hear the speech when there's a competing talker. That's the one that kills you, right? It's when there's two people talking at the same time. And remember, fear gave you the best understanding of words, right? It got your attention, and you were all alert, and you were all ears, and you could hear the words the best. When we artificially take the pitch cues and flatten them, so we're getting closer and closer to that neutral, boring voice, the word recognition goes down, except it stays bad and it is worse when older people listen to speech on speech. So what does that tell me? That tells me what is helping is being able to differentiate the voices of the two talkers. You still get an advantage of fear over neutral because it kind of tunes you into the voice cues. Okay, so all of those kind of issues you have when you're in a background noise or when you're with two talkers, you know, the emotion can make a difference. And if they're really excited or they're really fearful, you know, you might actually do better. So just think about that. I'm interested to hear your experiences. Now, if we look at this sort of a thing, with and without a hearing aid, now the good news is hearing aids allow you to hear more words. Thank goodness for that, because that's what they're supposed to do. But it's not as straightforward as it would be if we measured it with the boring voice. Okay, so we do get an advantage for word recognition, even if it's a vocal emotion of the person saying the word. There's a little bit of a change in the order, but we won't get into that. So if we think about, well, what could you do? What could your friend do? We know about clear speech. Some of the things that people would advise for clear speech, don't shout. Just, you know, speak in a normal but possibly a little louder voice, but don't shout because it wrecks those speech cues. Go a little slower. Gives you more time to think about what you're hearing. Lower your pitch a bit. So those might help you to hear words, but they might actually mess up some of the cues to emotion because all of those changes, you know, may revert speech to being a little bit more neutral. So if somebody's doing clear speech with you, it might just sound like the boring voice. And the boring voice is taking away some important information you might actually want to know about, even if you don't understand the word. So it's a bit tricky, but I think it's important. Now, as Barbara said, there are things you can do. Hearing aids are good for word recognition. They're not great, and cochlear implants aren't great for things that rely on pitch, like emotion. But you can be positive, and there is a very famous theory called the socio-emotional selectivity theory, and it basically is done by Laura Carstensen, who is very famous. You can see her TED Talks for talking about how older people get happy and they get positive. And it's not so much the number of people they interact with, but having high quality relationships with people you know. So I think that is kind of a slightly different agenda if you want to go out and meet people at a convention that you've never met before versus you're talking with your family. So your family can work with you to help you to get those emotional cues and to make sure that you're understanding each other fully and responding properly in the relationship aspects that depend on emotion. This is a fabulous book. I don't know if you've heard about it, but you can all read it. It's not a science book. It's based on good science. It's called Breaking the Age Code, and it's basically about how older people can become more positive. And this is the researcher, Becca Levy, who has really well-known studies showing that people who are more positive actually live longer. And she has shown that more positive people have less decline in their hearing. And, I reviewed that paper and I thought, oh, you've got to be kidding. There's no way that's true, because what does the ear have to do with this? But it is true, and she's done that work. Positive people walk faster. Positive people remember better. And this echoes some of what Barbara said. So my summary is, okay, I know somebody out there is happy. I hear some laughing. So emotion identification changes with age, whether or not you have a hearing loss. It does change with hearing loss. And these changes in recognizing emotion happen for facial emotion, not just vocal emotion. Emotion does affect how you recognize words. Hearing aids do help word recognition, even if the words are said with emotion, but they're not so helpful for actually helping you to identify emotion. But you can learn conversational skills, some of the recommendations Barbara had for rehab, and you can improve your health by staying positive and really working on the quality of your social relationships because they really matter. All right?
Okay, our next speaker was supposed to be Dr. Peter Dixon. I am not Dr. Dixon. Unfortunately, his flight got delayed, but he will be here in the afternoon for Meet the Experts. But I am up for the challenge to present his slides before I get to my presentation. And he was going to speak about the outcomes measurement in hearing care, considering the whole picture. So some of the things that are extremely important to talk about is how we can improve effectiveness, right? And that is through testing new technology, optimizing treatment programs, institutional priorities. But it's also, as you've heard, a large portion of it is also about counseling. So selecting the appropriate patients, how do we use that to predict outcomes, and also who are we comparing or using as our normative group? And then, of course, the important part is demonstrating benefit, which means how do we advocate for effective treatments? How do we get funding to do this? How can we use the outcome work that a lot of the panelists are speaking about today to influence policy and funding? So one of the things that Peter was going to talk about is the fact that most of audiology measures and outcomes typically get done in the sound booth, right? And Kathy was talking a little bit about that, that's not your real world. And I think it's kind of easy, it's interesting that it's easy for me to present somebody else's slides because I exactly have this same kind of thought process of, yes, we know that there's, that's where we begin in the sound booth. Yes, we know it's important, but it's not really giving us the whole entire picture of how you all are performing and what we could do to better improve outcomes. So when we look at things of quality of life, and words in quiet, sentences in noise, as you can see, he's kind of shown that sometimes we have data to show that there's poor correlations or maybe even no correlations at all. So that brings us to generic measures to assess quality of life. Part of that is also what we call PROMs, or patient-reported outcome measures. Now, generic measures, right, are applicable to all diseases and treatments. There's cross-program comparison, so you can compare, let's say, my work to the Canadian work, or to New York, and my work in Miami. Those kind of things where we're able to use the same measures to kind of go across different programs or treatment groups. It'll look at health status, it can look at health-related quality of life. When we use that, a lot of the data that typically before we had more condition-specific measures, which I'll talk about, one of the most common ones is the SF-36. And what that did is that it could assess domains as physical functioning, bodily pain, general health perception, but it also did have measures of social functioning, role functioning, and mental health. And so what he's showing here is that pre-cochlear implants, right, we saw lower scores, and then post-implantation, we saw improvements across those last three: social functioning, role functioning, and mental health. Now, condition-specific are applicable to a defined population. So that could be individuals with hearing loss, that could be individuals using hearing aids, and or CI users. Now, it does have its challenges where you can't meaningfully compare across different disease groups, but it does give us more specific information about hearing status and health-related quality of life specific to individuals with hearing loss. So it also has components as social skills, social functioning. It has emotion-specific domains that might include anxiety, depression, self-esteem, optimism, right, which we started to kind of hear about as well, or even feelings of anger. And what he's showing here in this work and the study that he cited is that overall, if we look at all of these graphs, and as you can see, since this is a research symposium and panel, we love to show graphs, but usually the message is really simple. We could follow the line. So as hearing severity increased, right, we are seeing more symptoms of depression or anxiety, anger. And we're also seeing that opposite happen in terms of self-esteem or feelings of being optimistic. So it really kind of shows that there is a relationship between hearing status and many of these feelings that, to be honest, we don't talk about. I love to hear now, that we're getting into these rooms, we're having these open conversations about things outside of hearing. Because as you've heard from our earlier speakers, yes, it's where we start, but there's so much more that we need to be doing to help improve overall outcomes over time. So one of the things that Peter developed and that his work has focused on is on health utility. When we talk about health utility, it's strange, but it has a 0, meaning essentially nothing, death, and then your perfect health, right? So it's like a 0 to 1, very categorical, as I say. And there's things that we look at that's termed quality-adjusted life years, and we have to use measures of health utility in order to do some of this cost-effectiveness work or cost analysis. Meaning, when we intervene, when we provide an intervention, is that improving, right, the impact on society, the impact on cost? And we need measures like this, like health utility, to be able to look at that. Now, there's measures, right, of health utility for a lot of different areas, right? So a common one is the HUI, and they have questions related to vision, to speech, to dexterity, emotion, as you see, cognition, pain. But hearing was really lacking, right? And so a lot of research was finding challenges with how do we do this cost-effectiveness work? And I actually just published a paper on this as well, where there wasn't really good measures to look at this. So Peter and his group actually developed the HUM, which is called the Hearing Utility Measure. And it is a health utility or health status measure that is specific for you guys, right? It looks at speech, it looks at environmental sounds, localization, listening effort, tinnitus, music, and assistive technology, and he's included those references there. And so, how did he do this? How did all this work started? Well, a lot of work when we talk about measure development happens via interviews and focus groups. It means we now have gone away as researchers of doing the work ourselves, but actually assessing or working more with the stakeholder group, which means the individuals that it's impacting, right? Which is you guys. So focus groups with individuals with hearing loss so that we are able to get information and words that you guys use to describe the various experiences that you might be having. All of that gets transcribed, and all of that then gets reviewed and coded to identify the themes that are coming up. And so this can, areas that kind of came up in this, conducting these focus groups are identity and self-image, right? So your view of yourself and the perception of others, feelings of isolation in group settings, which we heard Barbara talk about as well, importance of prior relationships, the development and the journey of the hearing loss. But then we also have autonomy and control. So what are other things that might be going on? Unavoidable social events, work, right? How is that impacting passive listening, spatial and situational awareness? Then there's other measures that looked at personality and dominant emotional status. There was also situational cost or benefit analysis with respect to use of hearing aids. And then another kind of component or theme came out, which was coordination of emotion, additional information related to communication technology, tinnitus, and given when the study was conducted, it was also the impact of COVID on emotions as well. And so some of this work that he's kind of referenced here is kind of really showing that relationship, again, as we've heard from prior speakers, of hearing loss and that relationship to cognitive decline, to hospital records and medications. But then other work, right, really has started to show, right, and talk more about also the impact on emotions or the impact of depression, the impact on just chronic conditions overall. One of the things that he uses to kind of describe, right, the impact is the Cohen Social Network Index, an SNI, and this is from one of the studies that's called Achieve. And what it did was looking at existing heart health study participants, comparing that to normal volunteers, but looking at looked at a large portion of individuals, 977 from the ages of 70 to 84. And looking at hearing intervention as well as aging health education control to look at semi-annual follow-up visits that then looked at things such as cognitive decline, which we know there's that relationship, executive functioning, which I kind of view as the conductor of a train. So if I think of executive functioning skills, it's your ability to plan, to organize, to initiate. And so executive function is that little conductor of the train that's going to make sure that you're able to kind of follow through in your other kind of steps. It does incorporate language and memory. But, again, you're starting to see when we talk about social network, mental health is coming in. Physical, social networks, all of these things are greatly important to better understanding the impact. So one of the studies here that's also cited was looking at factors associated with third-party disability in spouses of individuals with hearing involvement. And so very quickly today, when I kind of walked in this room, I got to meet some spouses who are here, right, championing and being support for, for you guys out there. And this really shows the importance of, again, this social network of family. And making sure that as we talk about this, and my talk definitely is a little more clinical of, it affects everybody. It doesn't just affect the person with hearing loss, but we have to be talking about this as from an entire social network. It could affect the full family. Are we providing those interventions? Are we talking about this in an open setting to figure out how we can improve and how we can help and guide the families that are walking through our doors? And there is a measure to assess this, which, it's good. It's called the SOS HEAR, so Significant Other Scale for Hearing Disability. And so that could kind of show how is this maybe hearing loss affecting your spouse, your significant other, and kind of can be used in a clinical setting to make sure that we're treating, as I like to say, the entire family. Other work here that he cited was social, emotional, and well-being and adult hearing loss and some clinical recommendations. And look who's cited there, Barbara. And it really kind of talks about, she obviously did a better job than what I'm going to say now here, given her work. But, identifying the clients or the participants' social emotional well-being, including the family members, incorporating the social emotional needs and goals in this individualized management plan, making sure that we have identified the hearing and the social emotional needs and goals to those recommendations, right? And that might include the hearing devices. It might include auditory and communication components, but it also can include social training, how to, conduct yourself in those social environments that might be a little bit more challenging. And then the use of counseling skills and techniques to explore and monitor your overall well-being. So his take-home points are, emotional and social domains are critical pieces of the puzzle. Not talked about a lot, but they are, and so I'm really happy to see that this is kind of coming up more and more in different meetings. But you also have to make sure that we're selecting and using the measurement strategy that best suits the measurement need, right? And so that could be prompts or patient-reported outcome measures, as I mentioned. It could be qualitative assessments. It could be the social network kind of approach, or it could be that third-party approach as well. And all of these things might be beneficial at some point in time. And measurement, as he's mentioned, is strategic but also continuous, right? So oftentimes we might look at this and measure, at one point, but then if someone doesn't kind of express concerns, then we forget to kind of continue monitoring. And so really we know that this changes, right? Some of us have good days, some of us have bad days, and we need to make sure that we're using these measurement techniques on a continuous basis. And here are his references, and hopefully if you guys have questions directly for Dr. Dixon, then he will be available later on to address your questions. Okay. Hopefully I'm going to pat myself on the back and say, I'm impressed that I went through those slides. Okay, now I could take a deep breath as I, get myself back together. And so I'm your next speaker. I am Ivette Cejas, and I'm also the moderator. So after my talk, we're going to have one more very exciting presentation by Gael, and then we will open the platform for discussion and questions. But I'm from the University of Miami, and I'm going to be talking about uncovering the truth about hearing loss and mental health. And let's just start talking, right? We need to just be talking about these things openly. So who am I? I always say I wear many hats, but oftentimes when I go to meetings for anything, for cochlear implants, anything hearing related, I'm usually the unicorn in the room and I'm one of the few psychologists, right? There's going to be always, otologists, physicians, absolutely, audiologists, speech and language pathologists. Not many psychologists, right, specialize in this area. And I have kind of grown to just dedicate my entire career to working with the hearing loss population. And so I wear the hat of directing the family support kind of program at the University of Miami because I realized we need this. We need to make sure that is available for families, for adults, anyone coming through the door. And while I say I'm a psychologist, that could mean researcher. That includes a lot of things, right? So I put this bubble because when we think about psychology, it kind of has a lot, right, going on. But what I'm going to challenge us all is to kind of think about mental health and taking care of ourselves, taking care of our mind. And I also, in many of my work, I try to self-reflect in that, yeah, I'm a mom too. I'm a professional. I would hope I have good coping skills, but not every day is a good day, right? And so I make sure that I use that as a role model when I'm working with some families. And sometimes I'm like, yep, today was tough, Today I woke up with a swollen eye. I had no idea I was going to do another presentation, but I'm here, right? I'm here. I'm ready. It talks about that excitement and challenging ourselves to, normalize the fact that sometimes we're going to feel sad, sometimes we're going to be scared, sometimes we're going to be anxious, but also realizing that there's ways for us to overcome these things. So if we look at this slide, I just want to kind of show each kind of little person here reflects 1 million adults in the US, right? And that's using kind of census from 2021. So roughly, if we see this here, that's 258 million total. Now, I don't know if you could see very well, but the red, it basically is now of those, right, of the entire population, 57.8 million had a mental health or reported mental health illness, right? But what I want to attract your eyes is that only 26.5 of those received any treatment, right? So unfortunately, there's still stigma. We don't talk about this, right? Everybody wants to hide. Everyone wants to say, I'm okay, right? But what does that mean, right? And we still could be okay, but that doesn't mean that sometimes we're anxious, we're scared. You know, I just watched that new movie Inside Out too with my kids, right? And I love the fact that they introduced a new character, which one was boredom, so it reminded me a lot about what Kathy was talking about, but one was anxiety. And, you know, it brought up a lot of interesting conversations of what happens to us when our minds, right, are kind of not kind of feeling grounded, and how we might need others or other emotions to help settle us down. So I think they did a really nice job capturing that. But as you've heard today, right, depression and hearing loss, there is an increased risk. We know this, right? And a lot of this stems right from that social isolation piece. You know, hearing loss, right, in general, when we look at the literature, higher levels of depression, right, we're seeing this. You know, one study reported for every 20 dB, there's about 1.3 more chances to kind of have these clinically significant symptoms. Another study said that 25 to 38% of children with hearing loss reported internalizing symptoms, okay? Another one that's showing that even as early as adolescence, some, right, adolescents with hearing loss are reporting these elevated symptoms. And that actual work was actually done from my clinic, where I was surprised that by the time I was seeing, you know, these older, you know, adolescents and young adults, they already had been kind of grieving and dealing with these emotions. So we did a screener where we just screened everybody coming in through the doors. And I was shocked that it was 25% because I had no idea, right? Because we don't wear that. You can't see it, right? Sometimes we try to hide our emotions, our feelings. It's not something that we come out usually and start talking about, right? And so for us, that was a big eye-opener. For myself, that was a big eye-opener as well, and knowing that we need to be doing more, we need to be doing better to encourage these open communications. Other studies have said about 15%, you know, of adults with hearing loss, you know, experience some kind of depression over their lifetime. And we do know that women in general, right, are more affected by any kind of mood condition. So it is something that I kind of keep my eyes on in knowing that it's something we have to be talking about. And so why is this, right? And you've heard from some of our panelists today, right? It's because there's this withdrawing from situations, right? That could be difficult. It could be the social gathering piece. It could be restaurants. It could be noisy environments. You know, it's reduced activation. Other studies kind of hypothesize that it's reduced activation in the central, you know, auditory pathways, and all of these things related to cognition, executive functioning, right, are related to our ability to regulate our emotions, right? So if we think about this, sometimes it's a little bit of a downward spiral that starts to happen. And so just like with anything else, if we catch it early, if we realize that it's there, we could do something before it is actually clinically important, right? And like I said, we all feel sad, we all have rough days, and so what can we do in the meantime to make sure we openly discuss those initial feelings before it gets a little bit out of control? Anxiety has the same pattern, right? We're seeing a lot of work coming out that just shows, right, hearing loss increases the risk, right, of developing anxiety. And this presentation is not meant, right, to say, oh my gosh, if I'm not feeling this, am I going to? It's just meant to know if you're in the room feeling these things, chances are you're not alone in it. And there's ways that we can improve that. There's therapies, there's brief interventions that we could start incorporating into our practices that can make this better. One study, again, specifically was saying even a 10 dB increase, right, in terms of PTA, increases your odds of having anxiety by 12%. you know? And so these are things that we have to start talking about. As we mentioned, earlier as well, we do know that though hearing intervention, right? So your hearing devices, your access to technology does reduce this on its own, okay? So without even any intervention, mental health, no counseling, just the fact that you have intervened by getting access to technology already is decreasing those odds. So just keep that in mind, and that for us is if you know somebody, right, with hearing loss who's having those difficult decisions of, do I want to wear this? Do I need to wear this? Look, we can know that it's also, if you don't have access to technology, if it's affecting you in other ways, that could also impact your mental health overall. Now, again, very similar. Why is anxiety higher? We've talked about it. Essentially every speaker has mentioned social situations, right? Everybody has. It just could be more difficult. It's those feelings of isolation. It is the fear of missing important information. I like this figure, although it's like very busy, because it just kind of shows all of the things that go through you could potentially go through your mind of, what if I misunderstand someone? And I embarrass myself, What if I don't hear something important? And what if, my tinnitus gets worse? All of these things. But this just kind of shows anxiety, and I'm an open book. The families I work with, the patients I work with all know that I am. Even with my residents and my trainees, I let them know when I'm having a bad day. It's pretty obvious because I'm usually like this, very excited and bubbly, so I kind of give them a heads up. But I'm also very open to kind of share what's crossing my mind, So this morning I was like, oh my gosh, I am so embarrassed. My eye was swollen. Some of these people are going to meet me for the first time. How embarrassing, And then I had to talk myself off of it, saying, are they really going to pay attention to your eye, or are they going to pay attention to what you're saying, right? And the message. But that was my reaction of, I had already, right? I could have used that and could have completely changed the way that I was, interacting with you guys today and presenting. Because if I already had a negative self-image about myself in my initial, interaction with you guys, then it could have turned out way different, right? So again, those feelings were there, those thoughts were there. I chose to go one way versus another. And that's what it is. It's choices. It's knowing we're gonna have these days, but what can we do differently about it? And how can technology help, right? We've already mentioned this, and a lot of the panelists have also mentioned that intervention by itself is helpful. Participants, again, we have evidence to show that there's significant improvement, right, after getting cochlear implants. Use of hearing aids associated with decreased psychological distress, right? And there's plenty more that you have access to in this slide deck in terms of resources, so it's all there. But, I like to talk about, this mental health is in the middle. It's in the middle of all of these things. It's in the middle of our relationships. It's in the middle of our physical health, of work, of hobbies, of interests, all of these things, and you have that in the center, right? And what can we do about it, right? I always say, okay, great. We have something, now what do we do, right? And like anything, I actually give the next way I think about this. I'm very much similar whether I'm talking to a group of professionals or hearing health providers, or if I'm just talking with families, with adults. Of the first step in anything is identification. We need to figure out what's going on. Are we using that? Are we able to kind of realize when maybe we're in one of these things? And, I always talk about anxiety and depression can be episodes. It doesn't mean you're always sad or depressed or you're always anxious. Most of the time, it's something has happened, I'm sure poor Dr. Dixon is having anxiety when his flight got delayed and wasn't here, right? He's very much, I'm sure, gonna express himself when he interacts. He's like, please apologize to the panelists. And I'm saying, don't worry, we have you covered, right? So again, right, we could shift, and I said, don't worry, I'll do your talk. You'll get to still meet with everybody and answer the questions, right? And they'll get to hear from you as well. But how can we identify those? Because without identification, we really can't truly evaluate to know whether it's just these normal feelings that are going up and down, or if it's something that maybe needs a little bit of clinical intervention. Right? So the next piece is intervention. And all of this is important. The identification, evaluation to intervention. Why does this all matter? Because we know there's better outcomes, right? In general. And when I talk about better outcomes, I'm a very holistic person of meaning globally, right? I talk about, even in pediatrics, I say I'm not just here to talk about your child's ears or even language. I'm here to talk about the whole child. And the same is true for adults. We are people. And as people, social interactions are important and emotions are important. So what is depression? How do we know if it's really like depression, right? And I'm sure many of us can kind of think about, we have felt all of these feelings at some point, right? And so the number one thing, even if you ask a child or an adolescent, they're like, nope, I'm not, right? First answer is usually a protective factor of like, I'm not feeling this, I'm okay. And I was challenged. I was like, really? You've never had a day that you're irritable or sad, right? Forcing us to kind of talk about it, because usually we protect ourselves to share that, right? Some people feel that, and I say this again because that's why I'm here, they feel like if I say it, I'm weak. Someone's going to think something's wrong. It's not true, right? So I pushed myself and I said, well, I've had bad days. And I start this from very little. I started with my kids who are 7 and 8 years old of like, oh, you're upset, labeling their emotions, right? Knowing that it is okay. But things that really can differentiate between just feeling maybe sad to it being something you're maybe should get more support in is the fact if you start to lose interest in things you enjoyed doing before, right? It is that removal of yourself from these social situations that starts to kind of give us a little bit of idea of we need to act, we need to intervene. It's, noticing changes in your sleep or even eating, that consistent, more feeling of sadness, right? Like I said, you could feel sad sometimes, that's normal. You could feel sad a few days, especially if there's something different that changed in your life. But it is that prolonged feeling, right? That is, if you're feeling that way for weeks at a time, that is where we start to say, you know what, let's talk about it. Same thing for anxiety, right? Anxiety, I would say more and more I've noticed, and especially after the pandemic, that anxiety has become something that has increased greatly, even in children. I see it very little, very young, of a lot of pressure, a lot of changes, and it's something that I think we're trying to, as a community, trying to get a hold of. But it's that feeling of restlessness. It's the feeling of, difficulty even concentrating. It's difficulties again with sleep, your changing patterns, that, that feeling of you're like constantly tense, easily fatigued. Those kind of things could be indicators. But anxiety does have a big component where there's physiological, right? It's your heart racing, you're sweating, some of those things that, like I said, when I was going through Peter's slides, I felt a few of those, right? To say, okay, you're a little uncomfortable. But that's normal, right? That's a normal situation. But again, if we're feeling these things for an excessive period of time or every day, that is something that maybe we should seek a little bit of attention. So I put this out there because I always talk about screening measures, and I always like to educate others, whether you're yourself going to take a screener or whether you're a provider and want to have access to screeners. There's a lot available that are free, that are quick. My favorite, the one that I use in clinic, just because it is the quickest, it's also freely available, you can go online and you can look at it, is the PHQ-8, meaning it only has 8 questions. And so it is a screener, it takes less than 5 minutes, and it could just give you an idea of, okay, if I'm a little bit concerned, I'm not sure whether I should talk to somebody about this, whether I should seek help for this. It could give you an indicator, right, of what those symptoms are. It'll tell you if it's mild, if it's moderate, or maybe if you need more attention. So PHQ-8 would be if you want to kind of take the screener and figure it out. It's great. Actually, according to the Academy of Pediatrics, all children at their wellness checkups for adolescents and up get this screener. So again, it is something that now more and more we're using this to make sure that we're capturing any symptoms even early on into childhood. And then again, here are just some measures that you can have for anxiety. The quick one that I used as part of our study and that we use in our clinic to screen adolescents and adults is the GAD-7. Again, free, available in several languages, only 7 items, takes less than 5 minutes. So again, something that you could quickly do and that it's freely available as well and online. So what do you do? What are some, if you're in the room and think like, I've kind of thought about this for a while, but like, what do I do? Where do I go? What should I do, right? And it's finding the treatment, finding the resources that you might feel comfortable with first, right? It's all about how we feel comfortable. You might not be ready to go and, see someone like me yet, right? You might not want to see a psychologist, right? You might want to talk to your primary care physician. That's sometimes where people begin, and that's okay. Some people are saying, I do want to go ahead and get those interventions, and so there are many sites that you can look up to find professionals in your area. You will have my email address, and so if you want to know if there's someone around in your area or your state that has worked with individuals with hearing loss, feel free to reach out to me, and I'm happy to kind of address those questions, given that there is a small number of us. So. But I can definitely help support that. But then some people are saying, I'm not ready for any of that. I just want to do this online. I want to do something, more gradual. And so there are various apps that people have found to be, helpful. My number one recommendation is don't get discouraged if your first therapist isn't a good fit. Many times, when I've met with people, they're like, oh, I tried this and it didn't work, right? You need to, just like you would for your audiologist or anybody else, if you're not feeling that there's a good match, if you feel you're not comfortable in getting what you needed from those interventions, find a new one. That's okay. It is your right. You want to make sure that the person you are talking to about these things is somebody who's going to listen and be able to provide that sensitive care that you guys all might need. And there's even studies that saying 48% of people who've met with 2 or more therapists before finding the right one that they felt comfortable. So this is a normal process. Prevention and early identification, other things we could do. These sound very simple, but they are effective in terms of exercising, mindfulness, social groups. Finding a peer connection is important. Having your regular checkups, but also being honest and transparent during those could be really helpful. Eating well, exercising, good sleeping patterns, having, structure to kind of your sleeping is also very effective. And just knowing that, sometimes these feelings don't go away on their own. That is normal. And that seeking intervention early is going to help it before, right? You have these feelings of, now it's gone a little bit too far. And so again, the earlier we act, as well as with hearing intervention, same is for mental health. Other things you could do, right? It's just all of this, right? Your family support, your formal support, getting information, finding those connections, using your communities. A lot of people, will tell me, that their neighborhood or their church really is a good resource for them, and that's where they went first. It's finding whatever you feel comfortable with, but knowing that a lot of people might have to be involved in order to get that support. But if you're someone who truly says, I have struggled with maybe some of these feelings of depression or anxiety, the good thing is that the interventions are pretty much the same, right? So if you're going to remember one type of effective treatment, I just want you to remember cognitive behavioral therapy, which is the intervention for anxiety, depression, but guess what? It's also a recommendation for tinnitus. So if you're going to remember one thing, it's that. It's called CBT. But there's other ones like mindfulness-based therapy, interpersonal therapy too, that are also available. But CBT, since I mentioned, is the one that's a priority. It works on, changing your thinking patterns, recognizing that sometimes we have these distortions in our mind that we put there. It helps to develop a greater sense of confidence, getting a better understanding of, behavior and motivation, using problem solving, learning to calm your mind and relax your body. So it will support that, but most importantly, changing those patterns that we sometimes kind of have. interpersonal therapy, just like if you are more of a person that kind of just wants to talk through some of these things, it definitely is a more relaxed and supportive type of intervention. It takes a little bit longer, but again, it deals with specific strategies to deal with a problem area. It helps you identify those interpersonal deficits and kind of works through these 3 different phases. Mindfulness has really taken off, and I know there's a lot of mindfulness apps, there's a lot of yoga, all of this, but actually it's been shown to be very effective even with young kids. And so there are mindfulness-based CBT therapy models that help to reduce stress, because sometimes stress is the primary influencer for some of these mood conditions. So again, just kind of keeping that in mind. But then other things, right? Just if you're not ready to go get formal intervention, there's these core strategies to manage your stress and anxiety, right? Again, centering, it's this meditation, it's like those yoga, it's doing this in your own personal space maybe. Expressive and creative strategies like going out, using art, using physical movement, right? Exercise classes, group settings, things like that could really be helpful. Exploration, sometimes, right? The way I get teenagers especially to do it is by journaling, because they might not want to tell me what happened, but at least they might write it down, and so I can kind of gauge that conversation, so journaling could help. And again, those overall healthy lifestyles that have been shown repeatedly, what we put into our body, our nutrition, our exercise, is really important, right? I always say it's the hardest one, because after I had children, lots of things changed, right? And my exercise and my eating, but it does have a direct link with our mood. And so if we could use that as well, it's really helpful. But what you'll notice is this is very similar to then how we can ourselves manage, right, these episodes. It's doing things you enjoy. It's staying active. It is practicing this relaxation, talking to somebody, engaging with someone, even though it might be difficult. And sometimes if you need to have a good cry, go for it. I am not the person to push the tissue box. I'll have it on there on the side, but I'm never going to stop it, because guess what? Sometimes when we're very frustrated and overwhelmed, the tears come, and that is okay. It is making sure that we are releasing instead of holding within. So with that, I want to thank you guys all for your attention. And next up, and I'm very excited about this next presentation. It's actually from an HLAA, I've heard, member extraordinaire, who will present the emotions of hearing loss, but through various vignettes. So let's welcome Gael up to the stage.
If you feel comfortable, no, I'm fine, I'll just. Am I on? Am I on? Great. Wow. Really, what they said, okay, amazing. Hearing loss affects communication, and communication is a human need. It's right up there with food, with water, with air, with sex, and wine. Those are the important things, and that's what hearing loss affects, our communication. And I would like to spend a little bit of time with you to put some faces on the emotions of hearing loss and meet a few people. And you will recognize yourself somewhere in there, I'm sure. So, I've lost my hearing, and I want it back. Through the years, it has seeped away, silent, unseen, a slow dripping of the sense of sound, a weakening of words, a wearing down of connections. And in moments that are shocking, I realized that the shape of my audiogram is shifting downwards. Where am I on the chronological timeline of coping with hearing loss? They say we grieve, moving from denial to anger to finally acceptance. Well, that sounds easy, doesn't it? Like going through the levels of a child's game until finally you win. I know where the starting line is, but where's the finish line? What happens when I cross it? Who applauds? What's the prize? What will be different now? You know, I thought I had crossed that finish line and grabbed the brass ring. But damn, there are days when I feel like I'm going around that racetrack one more time. Days when every, pardon me, is like a knife on my tongue. Days when every, oh, never mind, is like a punch in my gut. And days when I'm at the audiologist and I don't want to be there, but I know that this is the only place that I can go and say, I've lost my hearing and I want it back. Does a tear make a sound when it glides down the cheek? Can you hear my embarrassment when I get things wrong? How noisy is my frustration when I lose yet another conversation? Today's just a bad hearing day, I guess. Tomorrow will be better, but today, I've lost my hearing and I want it back. I'd like you to meet Bob. Bob is at the bar after work, meeting Mike for a drink. I don't know what's going through Margaret, what's through her mind, what she's going through. Maybe the change, you know? I don't know. Pardon? Oh, the job? Oh, it's all right. It's all right. It's sure not the same, though, Mike, I'll tell you that. I miss being out on the shop floor with all the action, the presses, but that's the problem, eh? And it was good of the company to give me this desk job away from all that and preserve what I've got left. But it's just not me, you know? I said to the guys who work there now, I said, hey, fellas, I ran those machines for 20 years. I know them pretty good, so got any problems? Come and see me. But they just smile and nod and say stuff like, sure, Bob, we'll do that. But they don't. They seem to think when you lose your hearing, you lose your brains along with it. Say, pardon me a couple of times, they treat you like a moron. Anyways, no skin off my nose, I'm just trying to help. What do you have? Huh? A beer? You know, you and Karen should come on over and we'll play some cards or something. Margaret would like that. Like I say, she's been kind of tense lately. Hey, what does it take for a guy to get a beer around here? Huh? Oh, no, it's nothing serious, just a phase we're going through. We've been married a long time, we've been through worse than this. It changes things, you know, like the way we communicate. I know it's hard to explain. You get into certain habits when you've been married a long time, you know that. You develop patterns, and now they're all out of whack. Well, she'll forget sometimes, and she'll start talking to me and when I'm driving the car. Now, she knows I can't understand her if I can't look at her. And she'll talk to me from another room and gets upset because she has to repeat herself. Other times, she goes overboard to help me, like she answers for me. I mean, I know she's just trying to help, but it makes you feel, last week, she was convinced that she heard a prowler in the backyard. Now, I take these out at night, didn't hear a thing. She woke me up and, whoa, was she scared and carrying on. At one point she said, my God, Bob, someone could break in here and you wouldn't hear a thing. What good? You know, there's a lot of things, Mike, that I don't hear, but I heard the words she didn't say. What good are you? Anyways, no skin on my nose. I try and cope with it, but hi. 2 very large beers, please. Now, I'd like you to meet a woman. She doesn't have a name, but she's over visiting her older mother, and yeah. Mom, can you turn down the music, please? Mom, I didn't ask you to turn it off. I just asked you to turn it down. I can't hear myself think. Well, I like Mozart too, Mom, just not that loud. I can't hear myself think. It wasn't, Mom, maybe if you wore your hearing aids. You do need them. Yes, you do. Yeah, Mom, I'm not having this argument again. I'm not saying you're an old lady. I'm just saying if you wore your hearing aids, you might hear better. You don't hear fine. You pretend to hear fine. I mean, you think you're fooling everybody, but you're only fooling your, forget it. Mom, I don't want to hurt you, but you're not fooling anyone. Like you didn't quit playing cards with the girl because it's boring, and you didn't quit answering the phone because, oh, it's never for me anyway. And you didn't quit going to the movies with me because, oh, they don't make them like they used to. Mom, you quit all of these things because of your hearing loss. You know, people don't even notice when you're wearing your hearing aids, but they sure notice when you don't. So why don't you quit being so stubborn? That's it. You are the most stubborn woman I have ever met. I'm stubborn? I'm stubborn? Look who's talking. Bossy thing. She gets that from her father. Sorry, sweetheart, but you could be a bit of a know-it-all, you know. Oh, Frank, let me tell you, it's no picnic, this growing old. It's always something. It starts with bifocals and goes right downhill from there. Aches, pains, stomach troubles, even whiskers on my chin, for God's sakes. But you know, Frank, that other stuff, it's not so bad. It's part of life. But this hearing loss has thrown me for a loop, I'll tell you that. Sure, I miss cards and movies, but that's bearable. It's my music. My music, Frank. You know what my music means to me. I try turning it up loud, but it's not the same. It's taken away my music, Frank. Oh, look at me, sitting here feeling sorry for myself. I know what you'd say. Dry your tears, woman. If you can't get over it, you better go around it. Okay. Okay, I will try those hearing aids one more time, but I am not going to let her think it was because of her nagging bossy thing. And then this could be anyone. This could be anyone. That's the thing that gets me. That's the thing that makes me clench my fist, my jaw, my brain. Usually I just let it go, or sometimes I deal with it gracefully as a teachable moment. But other times I'm like this. Don't you say never mind or don't worry about it to me. Don't you dare cast me aside. Don't you dare dismiss me. You don't have that right to say that to me. Now, I get that you think that what you said really wasn't worth repeating, but you don't get to be the judge of that. We're talking together. I'm hearing you. I'm talking with you. Do not make, never mind, the hill that our communication dies on. Because I mind. So now, could you kindly repeat what you said? Although I'm really not that interested anymore. But then there's also gratitude and hope and love. Let's meet this woman who is attending the HLAA convention for the very first time, and she gets up her nerve to ask a question in a workshop, and she's got hold on that microphone, and she's like, hi, I'm Eileen from Meadville, PA, and I have sensorineural hearing loss that's biliteral, you know, on both sides. And they think from birth, but they're not sure. But I'm sure because I remember being hard of hearing in grade 3. And boy, were those kids mean. I mean, HLAA should do something about bullying kids, but I survived it, and I never thought I would get married, but I did. Oh, it's really hard being married to a hearing person. Do they always talk while they're walking away? But, pardon? My question? Well, I don't really have a question, I guess. I just wanted to say that this is my first time here, and it's been so amazing, and you're also amazing, and I just wanted to say hello from Eileen from Meadville, PA. And the rest of us, while she's going through this, we're like, oh my God, Eileen, get to the question. But then she hits us hard at the end, and we get all misty, and we're like, way to go, way to go. And now I'd like to invite you into my bedroom. It's not what you think. This is called Lips at My Pillow. In the soft gray of not quite day, his sweet, sour breath pats my cheek in puffs of soundless words. Drowsy, I pull his 5-year-old voice close to my ear. Mommy, can I get up now? My grunt is taken for a yes, and I feel the vibration of his feet thump, thump, thumping out of the room. Turning on the pillow, I see you, eyes closed, but lips smiling at mother and son. Your lips move. Answering, I feel my voice in my throat. Morning, love. You fall back asleep, and I watch you, those lips. I can read their every nuance. They tell me everything. When you are about to make a joke, when a kiss is blowing my way, when they tighten in anger and soften in love. I can read you and our son. This language I know. And should I ever lose the last shred of sound, I will always understand you. Your voices will remain in my ears, and I will always understand you through your eyes, your smiles, your lips. And every morning, I will have your lips at my pillow. Thank you. And I just want to end with another piece of gratitude towards the technology that makes the hearing loss life better, improves our journey. And it's a piece that I wrote to a previous hearing aid, and it's called Ode to an Aid. Before I say goodnight, I'm looking at you closely for the first time in a long time, and I realize how much I care for you. And why? It's not because of your looks, 1 square inch of plastic and wires, your color referred to professionally as flesh tone, by people with no imagination as beige, and by me, in all honesty, is ugly. You know, for such a small creature, you sure have a lot of openings, but my favorite is that battery cage, and you clasp a fresh battery and disappear inside and immediately transform from a lifeless lump of plastic to a life-changing spark plug. You know what they say about beauty, don't you? It's what's inside that counts. But I don't think I really want to see inside, because I would be so disappointed not to see little elves making hearing magic. You know, I do love you, you know. And for all the times that I've cursed you, dropped you, stepped on you, let the dog eat you, I'm sorry. I expected too much from you, and you're not yet a perfect listening system. But I haven't thanked you for everything you have given me. You've given me back sounds that I had forgotten. You've given me sounds that never existed before my hearing went away, such as my baby breathing. So no, you're not pretty. You cost money. You're high maintenance. But if I didn't have you, I would be lost. I would be cut off from my people. So no, you're not pretty. You're beautiful. And I love you. Good night. So friends, all of these emotions, they will be with us on our journey. But what we have to do is accept them, recognize them, and say to the world, sing me your songs, world, because I am hearing as hard as I can. Thank you very much.
That's awesome. I know.
That was amazing.
Wow, that was amazing. Talk about, eliciting all sorts of emotions. That was beautiful. Gail.
Thank you.
And to the rest of the fellow panelists, it's been an honor to be on the same stage with you all and learn from everybody's perspectives. But we actually have a few minutes for any questions, thoughts, or comments. So there are microphones around the room. If anybody would like to ask any questions to any of the panelists from this morning's session.
I'll go ahead. I never want to step on anybody's toes. So first is thank you. Appreciate all of you being here. My question is the overlaps with some of the research. So isolation to me is two parts. Part of the isolation is just me talking to somebody that I know, but there's also isolation of not going to public events. And to me, that's all lumped together in the research. And I'm wondering if there's any research about specifically going out, so going to church, going to the theater, and then, of course, with my advocacy, using those assistive listening systems to be able to do that clearly.
Anybody?
Yeah, so are
Yep,
our mics
you're on.
Okay. That's a very good point, and thank you for asking it. So in some of the population studies, where different questions are asked, what you're talking about, like how much do you go out, would be called participation. And there really are questions about, do you go to this place and this place and this place? And there's a very long list. And that is something we did study in the Canadian Longitudinal Study on Aging. And that didn't differ so much in the people with hearing loss. They had fairly mild hearing loss, most of them. But it did matter on loneliness. So I think the kind of words that come to me are all the hard of hearing people I've met who say, yeah, I go to the party, I go to the conference, but I feel, like I'm not there, or I'm at the family dinner party. So they're going out, but they're not making the connection. And I think that's the difference between social isolation in terms of do you go out, and participation, we can count where you go, but it's the quality of what happens there. So I think Barbara tried to get at that difference, but there's, isolation, how many people do you interact with? Loneliness, how do you feel about it? Participation, do you get out? There's even questions about, how much of your time do you get out of your apartment? How much do you get out of your building? How much do you get out of your town? So those things can be measured. And then there's social support, which is huge. And social support and loneliness also are really coupled.
I just want to add to that. You could be socially connected and lonely. You could be lonely and socially connected. So there's not a, there's, we have to, the audiologist is responsible, should really ask about your social connections and also about your subjective feelings of loneliness. And I will say that the audiogram, which is the tool that most audiologists rely on, does not give the answer. So really, I would say that in terms of outcome measures, it's incumbent on you to say to the audiologist, this is how I'm feeling. You can't tell from the audiogram, this is how I'm feeling, how can you help me? So it's really, really important that you appreciate the fact that they are not related.
I think it's also, even audiologists sometimes can ask you, do you do this, do you do that, do you do the other thing? But, the goal is not to, fill up the scorecard. The goal is to prioritize the things that are important to you,
Right.
the things that make you happy, the things that you will keep doing, the things that will bring you success. And then, as you have successes, then you might tackle some other stuff that would not have been at the top of your list to begin with.
I just want to add one other thing. Interestingly, I did my dissertation on hearing loss, I don't want to say hearing loss, hearing difficulties, difficulty understanding speech, because hearing loss does not mean hearing difficulty. So I had to assess all these domains. And after that, I said I have to develop a questionnaire that will assess all these different domains. So I'm going to assess activity. Do you do this? Do you do that? Do you like to do this? But I want to also assess activity restrictions, because the extent to which you're restricting your engagement, most likely because you're not getting the feedback, you're not getting the quality of interactions that you would like, that's really what's important. So it's really important that we know what you're interested in doing, whether or not you're reducing this engagement, and how we can ensure that you're becoming engaged through the hearing aid that you so well, beautifully described, or the cochlear implant.
Okay, I know we started a few minutes late, but I would love to get through everybody's questions, so go ahead.
I'll be quick. First of all, this was fantastic. Thank you, everybody. So the studies that you all cited all make the distinction between people with hearing loss that is untreated and people with normal hearing. Or I know I'm not supposed to use the word normal, people with hearing that looks good on an audiogram. My question is, I think most of us here have treated our hearing loss. That's one reason we're here. And most of us also have pretty severe hearing loss. And so the treatment is not all that effective. And so I'm wondering, how do we fit into those studies about treated and untreated hearing loss?
Yeah, that's a great question, and one that I was even thinking about recently, where we don't have a good description of people in the room. We have description of very small little groups of individuals, and I think the next line of research really needs to look at, people like everybody in this room who has had intervention for extended periods of time, and how are those issues, or how are you guys functioning now? Because you're right, most studies are going to be comparing those who make a choice versus those who made a choice not to kind of seek intervention. In general, I would say that even some of the adolescent work that I had was individuals who had intervention, received it early. So there still is a risk factor that is involved, even if you get early treatment. But I do agree that more work needs to be done to look at that long-term effectiveness of the interventions.
I think it is true that most of the population studies, they might have an audiogram, they might have a self-report question. If you actually look at those two, they tell you different stories. Mm-hmm. So they're kind of correlated, but you can have a severe hearing loss, but say you're functioning well. Usually the census questions are using your hearing aid or device, how do you perform? And people can say they're doing excellent even though they have a severe loss. And I think that tells us people are doing well. And that's a good story. But there are people who the audiogram will say shouldn't be a problem. And they say, yes, I have a huge problem. And those are the ones that get turned away from clinics and not helped. So I think you have raised a good question. But I think that's also part of the sad story of this misleading headlines about, treat your hearing and you won't get dementia. Because then the people who have lived with hearing loss their entire life it's like, well, now what do I do? Basically, the only thing that has any kind of good evidence about preventing dementia is exercise. And so it's kind of do your exercise, eat your vegetables, be socially active, mental, physical, social activity. So I think there is a message that we are not giving to people who have treated hearing loss, but could do things to improve their health, their mental health, their physical health. And that's what's going to give you a healthy aging. So thanks for that question. I think it is, 1/5 of people who, according to the audiogram, should be having some treatment don't get it. So there's more people who don't have treatment. And I'm very careful when I write my results because I know it's an older person with this kind of an audiogram. I don't know if they're treated or not. I might have a question, do you have a hearing aid? But most of these studies, you don't even know if they use it. So it is a gigantic gap in the research.
And I just want to add that there was just a recent study on people with severe to profound hearing loss, and just a study devoted to that population. And I have a colleague in New York, a physician who is in the VA population, is looking at the population with severe to profound, because it's a population that is not getting there's not enough research, and we don't understand that population as well as we do. And he's looking at individuals with severe hearing loss who are hearing aid users, but most likely would be candidates for cochlear implants. But there's an issue with the funding of cochlear implantation in the Veterans Hospital. So it's something that people are getting more and more interested in.
The Gerontological Society of America had a special call out because basically it's like, yeah, we know a lot of people lose their, have declines of various sorts when they get older, but we don't know about people who've lived their life with disability. So now there's a bunch of us who are actually writing a paper about how we need to know more about this. So our feeling is people who have lived their life with hearing loss actually have some resilience that will benefit them because they've already been through, a lot of what Gail portrayed. They've already been through it. And so by the time they get to be older, they've actually got a few tricks up their sleeve that actually help them to do better. But it's uncharted water for all disabilities.
So I know time is officially up, so if you have somewhere else to go, feel free. But we're also still available for questions. So anybody who needs to leave, feel free to go ahead, but we'll make sure we'll answer these last kind of 3 questions and then we'll end. But feel free if you have to go somewhere else.
The afternoon session.
The captioning might be done now.
Oh, the captioning might be done. Trying to see anybody.
In the afternoon session, you may want to mention.
Yeah, I mean, there is also a Meet the Expert session that you'll have the opportunity to interact with us, but so if you want, I think everybody's gonna get up and go, but feel free to come over here and we're happy to answer your questions, but we'll go ahead and end the session.